Our next speaker is Gene Sung, and unfortunately, Gene could not be here, but he sent us a pre-recorded speech of what he wanted to tell us, and we specifically asked him to talk about the international footprint of neurocritical care, since Gene is currently the president of the World Federation of Intensive Care and Critical Care. He's actually the first neurointensivist to have done this, so this is really cool. It's really good for us, for our specialty. So I'm just going to play the video, and then we'll listen to Gene.
Hi, my name's Gene Sung. I'm from the NCCU class of 1996, where I did 2 years of fellowship, as well as then stayed on as junior faculty for a little while. So the title of the lecture that Jose asked me to give was, is the International Footprint of Neurocritical Care, Quo Vadis. But first, let me say a couple things. I'm so sorry not to be in Baltimore with everyone. It was really, really important for me to be there, but I had made a commitment that my family life would take precedence over my professional life. Of course, I never really followed that until COVID has happened. And so right now I'm in Asia for a big family event. I will say that the NCCU was the most meaningful professional experience of my life, and where many friendships were formed and many ideas percolated. And really, the NCCU experience was a little bit by chance. You know, it was I was doing my neurology residency at the University of Maryland, and about a quarter of the faculty had come from Hopkins, and they all recognized my early interest in the sickest patients. And so they gave me the idea of this new field called neurocritical care, which they had experienced at Hopkins. And as it also happened when I was looking for fellowships, both Mass General and the Columbia directors were having major changes. And then the other fellowship location, the University of Virginia, was not an option because of my wife's job. And so fortunately, I was accepted to the Hopkins program. And even with the experience of this kind of, at that time, semi-mandatory rotation as a resident prior to being accepted as a fellow, and me fumbling my way through lines, even though I was doing lines at Maryland with Johnny Yu looking over my shoulder, and me starting to get a little sweaty and nervous. I got accepted, and again, had one of the most important experiences of my life at Hopkins. So also, I'll have to mention that, again, especially after these last few years of COVID, you know, there really, really is an important benefit for electronic communication. And there are some advantages, but basically I hate Zoom and I hate virtual meetings. But at least I'll give you something right now, and I promise it'll be short. So getting to this talk, let's start with a definition of critical care medicine that comes from Wikipedia. So intensive care medicine, also called critical care medicine, is a medical specialty that deals with seriously or critically ill patients who have or are at risk of or recovering from conditions that may be life-threatening. So using this definition, neurocritical care has been around for millennia, right? So neurocritical care is prehistoric. You know, there was 40 treponated skulls found in France in 6500 BC, and more than 1500 trephine skulls from the Neolithic period have been uncovered throughout the world, from Europe, Siberia, China, and the Americas. And when you look at these skulls, a lot of them have showed signs of long-term healing and bony growth, meaning that these patients survived their neurosurgical procedures. And that means there are people who are taking care of these patients after their neurosurgical procedure. Perhaps, again, early neurocritical care. In fact, from the beginning of mankind, there are always people who cared for other people. In neurocritical care, diseases, some of these are trauma, post-neurosurgery, seizures, infections, not that different from what we do today. Continuing the Wikipedia definition, intensive care relies on multidisciplinary teams composed of many different health professionals. Such teams often include doctors, nurses, physical therapists, respiratory therapists, and pharmacists, among others. They usually work together in intensive care units within a hospital. And so Florence Nightingale, the famous nurse, born in 1820, established basically the intensive care unit concept, establishing monitoring units and putting the sickest patients near the nursing stations. And as an aside, I have to say that even with my great NCCU faculty, one of the most important learning experiences during my fellowship was from the NCCU nurses, and particularly Ski, the ultimate nurse manager, who maybe I was a little bit more afraid of than Dan, actually. And then we have early neurocritical care units, which was, of course, where? At Johns Hopkins. Probably the first neurocritical care unit in 1923 was a 3-bed neurosurgery ICU that Dr. Walter Dandy established. And now the final part of the definition in Wikipedia is critical care medicine includes providing life support, invasive monitoring techniques, resuscitation, and end-of-life care. Doctors in this specialty are often called intensive care physicians, critical care physicians, or intensivists. And so we have the idea that critical care involves advanced practices and technologies. And certainly in general critical care, one of the most important and established technologies is artificial ventilation. And so negative pressure ventilation was first documented in 1838, but the large polio epidemics brought about large respiratory units, which is arguably neurocritical care units, because these are patients suffering neurological diseases. And here, one of my sister hospitals at the University of Southern California, the Rancho Los Amigos Hospital in Los Angeles, again, huge units with patients with severe neurological diseases requiring advanced care. Positive pressure ventilation has been around since the 1700s, but again, also from the polio epidemic, and was a medical surgical ICU in Denmark that had around the clock neurocritical care with a team of 200 medical students providing positive pressure ventilation, which is basically bagging 24 hours a day, 7 days a week for patients with this severe neurological disease. But technology developed so that the positive pressure ventilation system was far more efficient and useful. And in fact, because of that, Dr. Peter Safar developed actually the first 24-hour-a-day, 7-day-a-week physician-run ICU at, of course, where? Baltimore City Hospital, now known as Johns Hopkins Bayview. Now, interestingly, 10 years after that, Safar, an anesthesiologist, Henry Weil, a pulmonologist, and William Shoemaker, a surgeon, started the idea of having a society for professionals providing critical care medicine. Almost 30 years after that came the idea of the Neurocritical Care Society, of which I was one of the founding members. However, importantly, again, we all had some of these different ideas rotating in our heads. For me, it came from my mentor, Dan Hanley, who had started NACABI, a research society for neurocritical care. It took about 3 years after we decided that we really needed our own society to have a formal founding in 2002. And from the beginning, the concept was that this would be a very multidisciplinary, inclusive society and international. And so the initial officers were included a neurosurgeon as well as a neurointensivist from Europe. And the mission was quality patient care, interdisciplinary collaboration, research, training and education, and growth. And growth was important, again, worldwide. There were some people who advocated to have an ultra elite neurocritical care society of true, quote unquote, true neurointensivists. But I argued differently, that we really needed to have all people involved and interested in neurocritical care, whether or not they took any official fellowship training or anything else. And we eventually developed 4 regional chapters of the Neurocritical Care Society: Asia, Mideast, Africa, North and Central America, and South America. And we now have over 25 partner societies worldwide. But neurocritical care practice changes. So you've all seen this already, that again, early neurocritical care units had many neuromuscular diseases, but this has changed as the advent of IVIG came about, and more community hospitals were able to take care of patients with severe myasthenia or GBS. Epilepsy, severe status epilepticus, is certainly a big part of neurocritical care units, but also now changing is the advent of different surgical interventions for epilepsy. And I think the biggest change is certainly come about because of advances in stroke care. So the advent of reperfusion therapies did a couple things. First of all, it made stroke a true emergency that brought more stroke patients, but as well as patients with intracerebral hemorrhage and subarachnoid hemorrhage to the larger stroke centers. But those patients needed to be often taken care of by neurointensivists. And also, the advent of reperfusion therapies brought about complications that neurointensivists were needed to help treat. And finally, the advent of technologies for reperfusion therapies have changed not just stroke, but also, for instance, some of the neurosurgical patient treatment options, such as aneurysmal subarachnoid hemorrhage. So all of these things change practice, but also changes who the neurocritical care unit patients population. It may eventually come to the point where this is kind of a blurry screen captures from Star Trek, but here Dr. McCoy and Captain Kirk go back in history to recover one of their officers who had a subdural hematoma. And as Dr. McCoy says, this is barbaric. They're going to open his skull to treat the subdural hematoma, and instead he placed a non-invasive monitor and therapy to treat the subdural hematoma. And this may eventually change again the practice of neurocritical care, because these patients may not require neurocritical care in the future. But neurocritical care around the world, so when I left Johns Hopkins, I thought, I know how neurocritical care needs to be performed. We need highly specialized units, closed intensive care unit, a dedicated team, et cetera, et cetera. These are rare, though, and often because of resource issues. So that even though I felt this was best, and I think the data shows this, this is not feasible in many, many places around the world, or even in the United States. Instead, I would say that most neurocritical care practice is general intensive care units that have at least one of the intensivists who has a dedicated interest and takes a lead on the practice, research, and education issues of all the other intensivists in that ICU. And that intensivist may not even be fellowship trained. But that might be okay. And certainly, again, because of resources, it's something that's going to happen throughout the world. So how do we take care of that? Well, certainly there has been a great deal of interest of neurocritical care. And so much so that I, a neurointensivist, a subspecialty intensivist, have now become the president of the World Federation of Intensive and Critical Care. So this organization has been around for 50 years now, and I'm the first subspecialty intensivist to lead it. And this our Congress, which actually occurs this August, so this is kind of a plug for the World Intensive and Critical Care Congress in Istanbul this fall, has significant neurocritical care topics in it. And in fact, I would say that all major critical care congresses throughout the world have significant amounts of neurocritical care topics in their congresses. And is because, again, most of the intensivists who are taking care of neurocritical care patients don't have that formal training. And so it has to be provided one way or another. Now, all talks I give now include some talks about COVID, right? And so we see the spread of COVID year after year through 23. And what we've learned is this, is that, again, many of us, and so myself included, have had a huge experience with COVID. I was one of the first physicians to have a suspected COVID patient in Los Angeles. A year after that, actually, is when we had our big outbreak in Los Angeles and had probably the biggest outbreak in the country, if not the world, at that particular time. And all the hospitals were swamped, but particularly our LA County USC Medical Center, which is one of the top 3 busiest hospitals in the US. And as we became swamped with COVID, all of the intensivists had to show up and help take care of these patients. And so in my units, probably at least half, if not more, of the patients actually had no neurological component that was requiring critical care. And in fact, these were general critical care patients or patients who were suffering with COVID alone. And we had to step up. And again, we know this, but it's heartening to see it in practice that neurointensivists are intensivists, and we stepped up and helped take care of the burden of all of these patients. We also have to deal with the new world, right? So I also put this in almost every talk I give nowadays, is there is a new world here of a significant portion that is anti-science and anti-expert. And the mantra is now everyone should do their own research. And what we have to say doesn't count. And in fact, this even goes all the way up to our governments and the politicians leading these governments. And here we have 3 former leaders of major democracies who had major missteps in their COVID policies. In fact, some not even believing in COVID, or not even believing in their experts telling them how to take care of these patients. And no surprise, all 3 of these, besides getting COVID themselves, probably were responsible for many people getting hurt or even dying. So the response has to be that all of us work together with facts and science. And so the importance of what we do as a field worldwide is important. Neurocritical care has been delivered around the world since the beginning of humankind. The need for quality neurocritical care continues to grow dramatically. And so to answer Jose's question, Quo Vadis, where do we go from here? The future is bright. I think that because of all of these new developments, neurocritical care continues to grow, but it will grow differently than we experienced at Hopkins. And that's okay. There are going to be different issues that everybody has, but nonetheless, I think the programs such as the Hopkins NCCU will lead the way for the research and education and science that we can transmit throughout the world. So again, I'm so sorry that I can't be there in person and to see all my old friends and colleagues and meet new ones, actually. There have been so many more since I've left, but hopefully we will meet someday in the future. Thank you very much.